Good evening, friends. Today we are going to discuss about the clinical case 7. So that is none other than Klumpke's paralysis. Welcome to my channel. Those who have not subscribed to my channel, please subscribe, like, comment, and share. Let us discuss about this clinical case. The condition which you are seeing here, you have to observe carefully. The condition is like this. A baby was delivered with a breech presentation. During the second stage of labor, the right arm was carried up above the head. In the picture, you can identify that arm has been raised above the head. So, what did you observe? The arm has come outside first. So, the right upper limb has come outside first. So, what the doctor has done is he took a forceps in order to bring the baby outside safely. So he pulled the arm outside. He pulled the baby outside. Then easily the delivery has been done. After that, assuming that 6 months later, again the doctor has asked to examine the child. So the mother brought the child to the hospital, and what she has observed, what mother has observed in that particular baby is his palm is something gone wrong. Right palm is something wrong. So the questions are like this. Describe exactly the position assumed by the fingers of the right hand and name the muscles that would show evidence of wasting. Second question is, it is assumed that first thoracic root of the brachial plexus had been severely damaged. Do you expect any sensory loss to occur in this case? Let us discuss about these two cases. Now try to observe this picture. This picture is a well-known picture which you have been studying from the beginning. That is nothing but the brachial plexus formation. So an injury to the lower trunk of brachial plexus can you find here? In this picture, you can identify the lower trunk has been formed by the joining of C8 and T1, and both are going to join with each other and forms the lower trunk of brachial plexus. So injury happened to the lower trunk of brachial plexus that causes the claw hand. So in the claw hand, what we can identify is medial four fingers, that is index, middle, ring finger, and little finger. These four fingers are hyperextended at the metacarpopharyngeal joints, hyperflexed at the interpharyngeal joint. Okay, so these two things you have to find out. The next one is there will be wasting of thenar and hypothenar muscles. Thenar and hypothenar muscles. So these things can be seen in the claw hand. So why claw hand? Why these muscles are getting infected? Because you are observing here in this picture from the medial cord of brachial plexus has been formed by this C8 and T1 segments. So those are giving the branches medial pectoral nerve, medial cutaneous nerve of the arm, medial cutaneous nerve of the forearm, then medial root of median nerve, and then ulnar nerve. So as ulnar nerve is involved in this case, ulnar nerve, as you know that it is supplying to the palmar interossei, dorsal interossei, then you can see the third and fourth lumbricus, hypothenar muscles. These are all the muscles are supplied by this ulnar nerve. So muscle wasting can be seen in this particular case. Then Klumpke's paralysis, that is called as lower trunk injury, that is called as Klumpke's paralysis. It is caused by the hyperabduction of the arm. This one we have discussed earlier. So because of the breech presentation, as the doctor has pulled the baby outside in order to bring the baby safely, in that trial, the baby has lower trunk of brachial plexus has been damaged. So the clinical features, what we can identify in the Klumpke's paralysis. Let us see that. Claw hand. As already we have discussed about the claw hand. So medial three fingers, hyper extended at the metacarpopharyngeal joints, hyperflexed at interpharyngeal joint. Then what is the reason for the loss of sensation along the medial border of the forearm and the hand? Because medial cutaneous nerve of the arm, medial cutaneous nerve of the forearm, these are supplying to the skin of the forearm medial aspect. That is the reason for the loss of sensation at the forearm and also the hand. Now, what is Horner syndrome? Horner syndrome, it is characterized by partial ptosis, so drooping of eyelid. The child, he could not open his eye properly, right eye, as the right hand has been affected. His right eye, he could not open it properly. Then meiosis, I will show that meiosis and anaphthalmos pictures so that you can understand. Anhidrosis means less secretion of sweat or low secretion of, absence of secretion of sweat can be seen. Anhidrosis. Why these conditions can be seen? Because due to involvement of sympathetic fibers supplying head and neck, which leave the spinal cord through the T1. So from the T1, the sympathetic nerves which are coming outside and extends upwards, and they are going to reach to the cervical sympathetic ganglion. From that, again the post-ganglion fibers, they reaches to the respective regions, the pupil, then you can identify the levator palpebrae superioris muscle, and also these sweat glands also. So that can be seen in this Horner syndrome. So in this first picture, you can identify meiosis. In the first meiosis, in the above picture, you can identify this is a normal one. Second, unilateral, you can identify the left eye is the pupil. Contraction of the pupil is more. Contraction of the pupil is more. That is meiosis. In the third picture, you can see that bilateral, that is both eyes, the pupil is contracted more. That is called as meiosis. In the second picture, you can identify anophthalmos, recession of eyeball. The eyeball is moved posteriorly. That is called as anophthalmos. So that is about the Klumpke's paralysis. See you soon with a new class. Thank you, dear friends. See you.